Okay, I think we'll get started since we have a very packed agenda today. So welcome and thank you all for joining. We're really excited about our session titled Enhancing Capacity for Global Implementation Science, Informing More Responsive, Equitable, Inclusive, and Effective Curricula and Training Approaches. My name is Emily Pekka, and I'm the Technical Director of USAID's Health Evaluation and Applied Research Development, or HERD project, based at University Research Company. And my role is to usher us through the session and provide some background and framing for our series of discussions. Please feel free to share comments and questions in the chat as we go, and our colleagues will do their best to respond. And if we are unable to respond, we will follow up post-event. We really look forward to your active participation. So today's session is hosted by the Implementation Science Collaborative, which is a major output of the USAID HERD project. The ISC brings together a mix of stakeholders spanning implementers, research and training institutions, evidence advocates, policy platforms, and other collaborators to address emerging health and inclusive development needs. Our anchor partners provide leadership across activities, and currently URC functions as the partnership secretariat. Within the umbrella of the ISC are thematic learning collaboratives, which advance evidence to use needs in the areas of mental health and psychosocial support, protecting children from violence, women-centered care, assistive technologies, and more. For additional information, please visit our site, iscollab.org, and be sure you're on our mailing list. We will follow up this event by producing a report and sharing materials on our website. Now that that's out of the way, we'd like to move into the substance of this session. And to do that, I would like to share a brief framing and some thoughts as a launching point for discussion. So before we begin, I'd like to acknowledge the diversity of terms related to implementation science and to signal that our conversation today is meant to be inclusive of those terms and that our objective is not to choose or promote certain language, but instead to advance a conversation about how to build skills and capacity to do it better. So for this reason, I offer a working example that our implementation science collaborative partners developed through a consultative process, and instead would rather reinforce the essence of implementation science for the purposes of this discussion. So why this conversation now? Most would agree that there is an increasing need for an appreciation of implementation science. And if this is true and we have growing consensus around the value of IS, it begs the question, what is required or what essential capacities are needed to be successful? And from experience, we know there are a range of capacities that are needed, from understanding context and the most relevant questions, to understanding what evidence exists and what the gaps are, the ability to produce and analyze existing evidence, the ability to integrate evidence into pathways of influence, and of course, the coordination, communication, connection, and knowledge management among the actors who are involved in the process. So today we'd like to have a conversation from different perspectives about how implementation science capacities are developed and how we can enhance responsiveness, inclusiveness, and equity in this domain going forward. In exploring these capacities, we will draw from issues that have become particularly critical as we manage the aftermath of the COVID-19 pandemic. So to provide some additional background context and information around what training materials exist, we conducted a modest online scan of resources. In addition to the online scan, we polled the panelists in today's sessions. And just to note, this is a preliminary review. To inform this conversation, the results are only in English, and we look forward to sharing the preliminary results with you near the end of the session during the break, and to get your feedback and amendments and input. So what did we find? Here are some key highlights. Total resource entries totaled 29, and the majority were resource hubs, followed by courses, programs, and a seminar series. The focus of the resources were often general, while some were disease specific. Most institution types that produced the resource were from high-income countries, and the majority of those resources were found online. Some were residential or in-person, and some were hybrid. Some came with a cost or a fee, and others not, and in some cases it was unclear. And there was a diversity in terms of how the audience was articulated, as you can see here. So if we think about what exists, there's a variety in terms of opportunities for capacity development, with the majority being self-directed or free online modules or resources. And as I noted, the majority were developed in high-income countries. And the focus was largely general, though some were focused around cancer, mental health, non-communicable diseases, et cetera. The audience tended to be a mix of researchers, implementers, or both, but it's important to note that about 1/3 did not specify a particular audience. And then I wanted to draw your attention to some of the potential barriers to access, language being one, and of course, our scan really only looked at those offered in English. Cost in terms of access and required fees, and then of course bandwidth and internet accessibility being another potential barrier. So with this in our minds, we invite the panels to provide perspectives on implementation science training and capacity development with a focus on the major questions here. So what training or capacity development efforts are working well? What needs are not being met? What capacities are underdeveloped or missing from our training opportunities? And how can we better leverage partnerships for implementation science capacity strengthening? So to do that, we have 3 panels. We're thrilled to have about 20 colleagues from about that many institutions join us today. And the first panel will offer perspectives from more of an implementation point of view. And then the second panel will examine these issues among colleagues from research and training institutions. And then after a short break, the third panel will help us consider the science of collaboration, or how can we do collaboration better, or what have we learned about implementation science-oriented collaborations and how they are able to enhance implementation science capacity. To help you get to know the colleagues on the panels better, we'll be circulating the short bio document so you can read more details about them. Since our time is short, we won't spend a lot of it on introductions. So, as my colleagues prepare to begin the first panel, I'd like to acknowledge the generous support of USAID through the HERD project for not only supporting this, but other critical conversations around advancing the field of implementation science and the application of implementation science to health and inclusive development priorities. And without further delay, we'd like to start off by engaging all of you in a brief poll. So get ready. My colleagues are going to send out a link, and this poll will help us get to know you a little bit better as we embark on the next conversation. So Monica, you want to go ahead and share that?
Yes, the polls are in the chat. 2 links, 2 separate links, poll 1 and 2.
Great. So if everyone can take just a second to complete the poll, we'd really appreciate it. In the meantime, I'll keep our colleagues' names here up on the screen as we prepare for the panels. Okay, can you let us know how many have done the poll? Are we ready to close it?
Yes, we can move on.
Great. It would be great to show the results if we're able to. We can also show them after the first panel.
That would be easiest. If that's okay.
Great. Okay. So now I will pass it over to the co-moderators of our first panel, which will highlight the perspectives from the implementers, and like to give a warm welcome and thank you to Laura Reichenbach from Population Council and Kauthar Afsana from JPG School of Public Health at Brock University.
Thank you, Emily, and thank you to the organizers for inviting us to moderate this session. I think we are going to start with very brief introductions. I understand the bios for our panelists have been shared, and I encourage everyone, it's an impressive panel, a little intimidating as from the moderator perspective. Afsana, do you want me to do brief introductions, or shall I just jump in and do brief intro, just highlight the panelists and then we can get started?
Yeah, sure.
Okay, great.
So we have 5 panelists. Thank you, Laura. We have 5 panelists today. Firstly, you can see that Monica Bandera, she's a PhD candidate in and also psychologist. And she is from the organization which is called Regional Psychosocial Support Initiative, which is in brief REPSSI. And then we have Anne Bonds, and she is the Director of Resilience Programs in HIAS. Then we have Diana Shamrat. She is from the University Research Company, and she's the Senior Improvement Advisor and Licensed Clinical Psychologist. In addition, we have also Regina Shanova MP, and she's also a professor and a psychologist. At this moment, she's the chief of party of the USAID project called the Renew Health Project. She's also a professor in one of the universities in Manila. We have also Anne Njuri, and she is also from Senior Technical Advisor from LVCT Health. And I think she's based in one of the countries in Africa. With that, I think we should start. Laura?
Great, thanks, Afsana. And I want to, before putting out the first question, and we're gonna provide the same question to each of the panelists and ask you to limit your response. It's a challenge, I know, because it's kind of a broad question, but to limit your response to 2 to 3 minutes. Before that, I just want to highlight the fact that this very rich series of panels this morning, the session, I think it's really telling, and I think it's great that it's starting off with your voices as implementers in this space of mental health and psychosocial support and implementation science capacity building. And I think that hearing from the implementation perspective, starting us off, I think is really a great way to start this series of panels. And with that, what we'd like to ask each of you to reflect on is kind of a process question in terms of what your experience is, either as in your individual capacity or your institutional experience with identifying the implementation research question. Emily referenced in the scan and some of the larger background, the importance of reflecting context in the definition, defining what the question is, and would love to hear from each of you very briefly how your experience in doing that. And maybe we will start off with you, Annie, because that's how you appear in my
Thanks very much. Thanks, and good to see everybody. My name is Annie, and I'm going to speak from the perspective of HIAS. We are an international humanitarian organization with programs in 22 countries. So talk a little bit about the field perspective as Laura has just highlighted. I think the important piece on the mental health and psychosocial support side is that we have been fortunate to have some very thoughtful and critical thinkers on field teams in the countries where we're implementing programs. So we've really had an opportunity across the years to have communities of practice to think through what are some of the issues and concerns coming up in terms of implementation, what's working, what's not, and what are the things that we need to dig into a little bit further. We've also, in direct implementation of research with support of URC, we've been able to hire research staff that also have programmatic background. And that has helped us a lot in thinking about how to ask the right questions, how to figure out what is it that we're really trying to identify in terms of implementation. Are we looking at evidence-informed practices? Are we looking at evidence-based practices? What is it that we're actually trying to understand? And especially given the diversity of locations where we work, trying to kind of adapt, as you've mentioned already, look at the context and what makes the most sense. The final thing I would say is that it's been a really cool opportunity for us from the implementation side to think about how do we bring the work together. So from a mental health and psychosocial support perspective, what's important for us from a protection lens, and how does that make sense as well for serving all of the people that are in need of support and figuring out what programming would make the most sense. Thanks a lot.
Thanks, Annie. That's a great response. Lots of fodder there for further conversation. Monica, could you please answer now? Thank you.
I think for us at REPC, working across different African countries, I think the sensitivity to context is key. I think we're moving more into a realization that contexts are very different, and the way in which mental health and psychosocial support, both the needs and the ways in which they are expressed, as well as the solutions to them, differ. And so this kind of idea that an evidence-based model or implementation science model that works somewhere else can be applicable everywhere in Africa is a bit problematic. So I think for us, it's really trying to figure out how do we address the cultural sensitivity and the context sensitivity, but then also have very clear links to researchers that understand the context better, because implementers like to implement, and that's the strength, but also trying to find what are the right questions with the implementers is key.
Thank you, Monica. And I think this issue of cultural sensitivity and adaptation is one that we'll definitely want to come back to in discussion. Diana, could you please give your perspective?
Sure. So greetings to everyone. So I'm already hearing some great comments, and Laura, I think the cultural part of it, I think we're all going to be talking about that, because I think from the implementer view that that's a critical component. So a couple of points from my years of URC working on implementation of quality improvement in low resource settings with vulnerable children and families. These are people often marginalized in healthcare and in society at large. And improvement science is aligned with implementation science with its focus on effective evidence-based interventions, trying to increase the use of those interventions. I expect that today the discussions, they're going to highlight the importance of designing implementation strategies to fit existing cultures, infrastructure, and practice of healthcare, the practice of the healthcare system. I think particularly in the area of mental health, we notice that we need to intentionally pay more attention to existing culture and issues of equity. So for now, I'll turn it back to you, Laura, and continue on that theme throughout the discussion.
Great, thank you so much, Diana. Regina, could I turn it to you for your reflection on this?
Hi, everyone, and good morning. So my reflection is coming from my experience as Chief of Party of the USAID Renew Health Project in the Philippines. So you might have heard about our ex-president's war on drugs and how punitive it was. You might have heard that he was also very anti-US. So you imagine us coming in as a USAID project, encouraging evidence-based and compassionate approaches to community-based drug rehab. Given this very sensitive political context, it was very important for us to work with the agencies and to know what is important to them and what they were ready for. So at the beginning of the project, an important role I had to play was as a strategic partner. I realized I was dealing with an old boys club. I was a new kid on the block, and I was female to boot. So an important strategy for us was to find allies, partners who were already working with the Department of Health. I also hired a DCOP who came from the health sector, the Department of Health, to help us navigate this particular institution. As a change agent, it was also important for us to know the decision makers who we needed to get as allies. And given the climate, we needed to make sure we listen first. And we really had to balance being an expert with not really coming across to tell them what they needed to do. As implementation scientists, we also needed to balance sort of the rigor versus realism. So even if, for example, we know that the gold standard in evidence-based interventions are RCTs, in our context, we could not do that because making people wait for treatment could cost them their lives. So we had to be very pragmatic and decide what is the best science we could do given our situation. So, you know, our journey was really difficult, but I'm actually also happy to share that this month we will be signing a formal partnership with the Department of Local Government, who will now be co-branding our products to scale. And it did take a change in government to happen, but it took a lot of patience and tenacity to get to this point. We're not there yet, but we've made major strides in the 4 years that we've been doing this. Thank you.
Thank you so much, Regina. And I think it's such a striking example. And I think we forget sometimes about the importance of the political context and how complex navigating that is for implementers. So I know that we'll want to be hearing more about those specific examples of how you did that. And I think this raising the issue around this balance between rigor and realism and responsiveness to the needs for evidence, I'm sure is something that we'll come back to, and I think is very relevant to the capacity building piece of this larger discussion. And Anne, if we could hear from you and your perspective at LBCT Health.
Thank you very much. And it's interesting hearing from the rest of the speakers. I'm learning a lot here. So I'll give the example of what you do here at LBCT Health. LBCT Health is a local NGO based in Nairobi, Kenya, where we do a lot of HIV care, treatment, prevention, testing, as well as gender-based violence and violence against children program. And how we work here is via a model called the RPP model, which is research, policy, and practice. And essentially, it's like a loop. So how do we identify our implementation science and research questions? Number one, part of our key things is in service delivery. So we are actually able to interact with service providers at facility-based, at community-based, able to understand how they implement some of the guidelines, the policies that we have in Kenya. And from that, you can actually be able to see where the gaps are when it comes to implementation. And this is not just in the facilities, also in the community when you're talking about demand creation. For every service that is there, there must be, or the intention is that for people who are affected, say, for example, by gender-based violence, they can actually be able to go to the facility and get the services. So with our arm in practice, we're actually able to take a step back and see whether the guidelines are being implemented on the ground as they should be, or the demand for the services is being created by observing how the community structures work. And from that, we're able to see what gaps are there in the practice angle of it. Another way we're also able to identify some of the implementation science research questions is that we, on the policy arm, the second P in our RPP model, where we are highly represented in what we call technical working groups here. Essentially, they are thematic-based roundtable forums, where some of the data that we collect from service statistics, some of the learnings that we have from practice-based knowledge is able to be represented to a multi-sectoral group. And from this one, you can actually be able to look at it from a data demand and use perspective or monitoring perspective. Like, for example, with GBV service uptake, from that national level or county level, what the gaps are at policy, and even in the whole policy document itself, whether it suffices enough to be able to give direction on how services need to be offered down at community and facility level. So right from that roundtable forums, we're able to identify some of the national priorities in terms of gaps from a national perspective, when it comes to offering services, when it comes to budgeting for these services, when it comes to how to mainstream gender, how to bring in issues that are very specific, for example, to children and offering services to them. You're able to get that very top level gaps. And from that, we are able to prioritize what our research, to identify what our research priorities are in country. Some of the things that we are very particular, even as we are thinking about the implementation science research questions, number one is understanding the context. And that has already been mentioned, almost going back to the basics, understanding the situational analysis, what are some of the driving factors that are leading to these issues. Another thing that we purpose and we like to identify from the onset, even as we're thinking about the implementation science research questions, is the research uptake. Right from the onset, even as you're thinking about these questions, we're already thinking of how the end is going to be, to who's, who will they serve, the evidence that we generate from the research, what will be its purpose, how will it be consumed by the practitioners, by the implementers, by the donors in country. So we're already starting to think about the research uptake activities for each question. And thirdly, some of the things that we also consider when it comes to implementation science and the research questions is its practicality at community level. So what we always think of from the onset is community-based participatory approaches, where we think of, for this research question, how can we engage the community from the word go, whether it's on demand creation, whether it's at the policy table, ensuring that their voices are heard there. So they're part of developing that research question right from the onset, right from the conception stage up until the research dissemination and any further research uptake activities that we want to design. So there's that component of co-designing, co-creation, and co-implementation of the research questions. Thank you.
Thank you, Anne. I think your mention of the engagement with the technical working group, and I know you've been very involved in the national policy in Kenya, but I think what's interesting and maybe to talk more about is the continued engagement, not just in the design, but in the implementation monitoring, which is where some of the identification of those needs and sort of feeding that back into the policy perspective. Lots of rich, I mean, already we have a whole day of things we could talk about. Afsana, I'm going to turn it over to you to build on some of this with the next question.
Thank you for all enriching reflections of the first question. I think I am becoming more enlightened. But now I think we need to also, there are so much experience you do have, but at the same time we know that we need also to do more. So one of the areas that we have been actually focusing is the capacity. So could you also share, I'm going to first again to Annie Bonds, right? Yeah, the first question is, the second question is what capacities do you think that is missing? And how do you also benefit further, in terms of developing capacity, in participating in the implementation research, and also how to also develop capacity in translating in knowledge into actions? This kind of capacity we need to have in implementation science. So would you reflect, Annie? Thank you
so much. Thanks so much. Yes, and I've already heard so many pieces I want to go back to reflect on, but maybe we could build together on this question. I think in reflection on the question about capacities, that would benefit from further development. This is actually something that we've talked quite extensively about at Highest with our academic partners, primarily Columbia University. We've had many conversations on this. I think one of the things that we focused on is that the field of implementation science is often focused on the translation of research into practice, rather than, or maybe emphasize more than practice into research. So maybe looking at kind of that continuum and how we emphasize on one rather than the other. So in our experience, we've really wanted to try and figure out what is the user perspective in implementation science? And that tends to be actually the people that we're serving and the teams on the ground that are doing the work. How can we better bring that user perspective into implementation science and help to build from there, rather than kind of the orientation I think that we often have, which is based out of the literature and the evidence reviews, and where we start oftentimes with some of the research questions and the bigger thinking around this field. We also have had quite a bit of discussion around the tools that are used oftentimes by the research teams. So whether or not these are practitioner oriented or practitioner focused, because we've had quite a bit of work around what is feasible, what can we actually do in a 30-minute interaction, whether it's research or implementation in this actual work, and what makes sense and what is actually going to really illustrate do no harm, what is actually going to help us really lift up the lives of the people that are being served, and figure out ways that we're trying to, really to improve their context and their surroundings. This has already been mentioned, but one of the pieces that we've looked at a lot is the implementation challenges. So how can we benefit? How can we really look to develop further? What are those challenges and what are the things that have not gone so well? And those aren't often the things that we want to highlight and talk about on panels like this or in other forums. But there's a lot to talk about, and there's a lot of learning that we can do from that perspective. And I think from there, the forums like this to be able to share back and think about how can we develop together what capacities would make the most sense from the field perspective. Thanks a lot.
Thank you so much. I think you have highlighted all important issues that what we need in our capacity development and even for translating the knowledge into practice. Those are critical issues we have to keep in mind. So I'm going to go to, for the sake of time, I think we're rushing. So Monica, now I'm turning to you. Monica, over to you, please.
Yes, thank you. Yeah, so I think for my side, it's we don't always have the right evidence for implementation science available for our practitioners and for our realities. So I completely agree with Annie, was it the previous speaker, to say, what conversations are taking place between implementers and researchers. I think what's worked well in REPC has been having research capacity that is programmatic, has programmatic knowledge or background. So you're almost talking the same language between both researchers and implementers, and that enables both researchers and implementers to challenge each other in terms of what's needed. But I think having better understanding of what implementers' realities are, and then addressing those more acutely would be useful in terms of capacity. The other capacity issue is around not necessarily capacity, but around access to implementation science. What is available that makes sense in my context? How do I access that information? How do I, as a practitioner and implementer, get trained in these evidence, in this implementation science without it taking a huge amount of my time? And then the other thing that I just wanted to add is that we also need to understand that context shift and change. So, and I think COVID made that so obvious to everyone, that something that works, communities change and shift all the time. And so we need to be kind of malleable to those changes as well as implementers and researchers.
Thank you, Monica. Thank you for also raising that important issues that have of what actually works and what not, and also how we can also reduce the gap between the implementers and the researchers. And this is a critical piece because science is so important, especially for the implementation. So that's why you are here today to discuss. I'm going to go to now Diana. Please, the same questions turning over to you.
Great, thanks. Annie and Monica have already given a great overview. One thing I would like to add is in terms of capacity building is around the issue of youth, of including a community of youth in design and implementation and monitoring of trainings, because I think they are ready and willing participants, and sometimes we miss their voices. So including that group in capacity building, and also marginalized people that their voices often are not heard. And so we know that we need participation from them in our design of capacity building. And those would include, of course, people with disabilities, people, sexual minorities, and different marginalized groups. I'll pass it on.
Thank you, Diana, to bring also the issues of all those people who we actually never, sometimes we miss them, not hearing their voice, especially the youth, the disabled, the sexual minorities. I think this is very important, that how in their capacity needs to be strengthened in terms of their involvement. Seemingly, if I heard you, that you also mentioned that this could be a kind of participatory kind of research in implementation science. So I'm going to go to Regina now. Regina, over to you now, the same question.
Thank you. So I don't want to repeat everything that people have already said, but I'm gonna go sort of the other side. We talk a lot about the sort of the technical skills in implementation science, you know, the research and development and designing. Maybe because in our case, it was such a political, environment. The soft skills in implementing and managing change were so salient at the beginning, which means understanding your levers for change, understanding how do you manage change in between institutions. So in a sense, we were doing a lot of organization development, but across institutions. So those were competencies that were super critical for our project, because even before you can get to sort of the technical solutions, we really had to deal with the more strategic issues, which is how do you get buy-in in a government that thinks that the solution to drugs is to kill people. So we really had to work sort of, the technologies had to take a backseat to getting buy-in first for the importance of treatment. So there, thank you.
Thank you, Regina. I think you also raised very important issues of soft skills. This is
Yes.
really important for all of us to acknowledge and to incorporate in our implementation science. So I'm going to go to Annie. Anne, over to you now. Sorry, do I pronounce your name correctly, Anne?
Yes, it's Anne. Others call me Annie. It's absolutely fine. So from our perspective, I think what I just need to acknowledge is that a lot of our implementation science is donor funded. And some of the challenges that we see is we can go to all the roundtables, sit down, identify our national priorities, but if they're not aligned to the donor priorities, then we get most of our questions not answered. The willpower, the skills to do the implementation science research is there, but it just doesn't align with the donors. And so those are some of the conversations, the difficult conversations that we have to have is how do we get the donors to acknowledge that as we are in countries, we are some of the local NGOs, we do know what the gaps are and they can resource mobilize, they can give us the funds for that. not just meeting their own interests, but our own national interests as well. So I don't know what the solution to that is, but those are some of the challenges that we experience. Another thing that we get to see a lot of is what is classified as evidence and what it is we want to generate from the implementation science. It goes back to the first point that I said of how we identify some of the research gaps or gaps in service delivery. A lot of our work relies also on local strategies that have not been evaluated at a grander scale as we know implementation science research is supposed to do. But we could almost swear by it by saying that it actually works. But for it to be acknowledged as evidence, it needs to, be in that local, in that global platform. It needs to be evaluated. It needs to be documented. And some of these things, if you go back to the nurses, if you go back to the doctors, they don't have the time for that. And yet they're doing brilliant work. So it's almost two ways, how to acknowledge that local-based practice has a place in implementation science, and how to integrate it into that so that maybe we can go to the level of developing evidence from that local-based practice. But even after we've done that, with or without the implementation, how to just document some of this, either as case studies or whatever documentation, whatever channel, so that you can get some of these things scaled up in the country, that we can make it into documents like what works. It says it's not been evaluated by Kenya, swears by it, and we can actually see this make a difference based on the voices of the practitioners on the ground. So I always find like that's the problem, the challenge that we seem to have. As LVCT Health, we do a lot of research, a lot of gender-based violence research as well, and a lot of violence against children research. But beyond writing publications, we've still not aced that way of turning it into materials that practitioners can be able to consume here and globally. So that translation from research into practice, it's a very specific skill set that I think I can say most of us lack. And also the use of the local data evidence and anecdotal evidence, be able to be scaled up to the level of it being called evidence as we know it in the research world. So those are just some of the challenges and areas where we see we can be able to benefit from given the opportunity.
No, thank you. I think we actually touched all those points which is needed for capacity development, especially in terms of who should be trained, who should what, how, and what tools we need to use and what skills we need to do. So these are also critical points, but we have other questions too. So over to Laura. Thank you so much for your response.
Thanks. And I want to build a little bit on, there's so many points that are resonating, but I think I want to merge two questions. And one is to raise kind of from the perspective of the space that you're working in terms of mental health and psychosocial support and protection and the areas that you work in, is there something special or unique about these areas? And I've heard something, I mean, I think, Anne, it was you who said, do no harm, and really ensuring, the protection of the communities and the users of services. I think someone else mentioned the unique cultural context of some of these issues. No one's mentioned stigma, but I think stigma is probably very relevant to some of these. So, in thinking about sort of, if you were to design and implement or inform the design of an implementation science course or training, what would be the focus that you would want to highlight that you think would be necessary to include in that, both from the perspective of you as implementers, but also drawing on this, what is unique or special about the space in which you're working? I hope I made that question clear. And I'm gonna just go down the line. So Annie, you're my next person.
Okay. Thanks a lot, Laura. This is a really great question. I'll try and be quick because I know we don't have a lot of time. I think when I hear that question, what's special, and then, what would we recommend around training? I think what's special are the people that we all are probably working with across teams and implementation. So I think the skill sets and the experiences and, the eye that they have for protection, as I've already mentioned, I think because of that, I think some bi-directional training. So rather than thinking about training as a one-way street in terms of what we need to prepare for, from the university or the institution side, how can we better pull in the reality of the field and perhaps start with that? So is there training that we could better do in terms of understanding this is what it looks like to implement a program? This was already raised, I think, in great detail by Anne or Regina, I can't remember, but thinking through the practicalities of what does it mean to implement a project? What does it mean to look for funding? What does it mean to have to think about supervision and consultation and concerns about some of the people that we interact with on a daily basis, trying to figure out shelter and food and basic services, helping to bring in some of those real world context and settings to start with. I think before we get into the implementation science methodology and tools would really help us orient towards, again, the end user, the people that we're trying to serve. And I think this would also help us to shift our language a bit in terms of how we talk about the work, what's necessary and what's not, and help us to get our priorities, I think, better in line around what we really need to train people on. Thanks a lot.
Thank you, Annie. I think it's a really compelling, I think the real world context of what the programmer faces, I think is so critical and important for this topic. Diana, could you please briefly respond to that?
Sure. It's always great following Annie because she has such great great answers, but then it's difficult because she gives such great answers. So I think around the area of mental health and psychosocial support, one area that I've been paying greater attention to around capacity building is not just on the interventions themselves, but on how do you integrate those interventions within other service delivery platforms, looking at sort of the systems within which we work. And Gina has already spoken to this, because getting away from the idea that it's just the capacity for individual interventions, such as some kind of, say, cognitive behavioral treatment intervention, so to looking at how do you integrate that within HIV care or integrate that within primary health care. So it makes it more complicated, but it's more real in terms of what we are having to face, because I'm beginning to feel like we have the evidence, some evidence, not enough. And of course, we always need to build that evidence base, but we have evidence for different interventions, but we still don't know how to integrate it within a system of care. And that is to me, the big challenge of the day. I'll pass it on.
Thanks, Diana, for raising that critical challenge of integration. Regina, can I turn it over to you?
Sure, thank you. So in our project, I brought in very good, technically competent people. And I found out, perhaps within the first year, that I needed to do a lot of capacity building, but this time in terms of sort of taking a public mental health perspective, because they were very used to sort of interventions at a very micro level. So that's one. The second was, we really needed to up their abilities to partner. How do you deal with difficult clients? And so something like motivational interviewing, which we use for clients, was very useful for our partnering as well, when you're dealing with resistance in terms of starting to introduce change. strategic thinking was very important because we needed to understand where do you enter and how do you push back, or when do you step back. So these sort of partnering abilities was quite important for us. Plus, because we were sort of professors, academe, we also needed to change our language. So being able to present and being able to laymanize and popularize the way that we explain difficult concepts was really critical to get buy-in. So there, thank you.
Great, thank you, Regina. And I think this issue of finding common language has come up several times, and maybe something we want to revisit. Anne, could I turn it to you for a brief reflection?
So what are some of the trainings that I feel like we require or would do us good? Certainly from the work that we've done, we are purposefully shifting from researcher-driven implementation to more community-driven implementation. I think this goes back to the community-based participatory approaches, because traditionally we would develop the guides as part of the implementation science. Once we've identified what the gaps are, go and subject the community members to these guides, walk away, go do the analysis, come back, disseminate to them, and we think that's a job done. But we are finding that the buy-in from community level, even for the evidence that we've generated, which is sound evidence, that's still not doing it up. So we almost have to have that shift, very deliberate shift on not having researcher-driven per se. Researchers play the role of oversight, having the communities as co-designers of the piece that you want to investigate, co-researchers employing methods like what you're doing right now, photo voice, where they're actually going, the community members themselves going and collecting data, and we are training them on how to utilize that data even in terms of analysis of some of the issues that they're going through at community level. So I think that is a skill that we are learning right now. We'd like it to be widespread so that you have even buy-in once the community members like they're part of the whole process rather than the traditional way. So that's a very specific skill set that I would wish most of us are able to employ, at least from where I come from. Another one is, again, bringing it back to the research uptake activities. Most of the incidences that I've seen is we just end at published journals, peer-reviewed journals, and that is a gold standard with every other implementation science research. But then now when you go back to the practice angle, back to our RPP model, we are asking the practitioners, have you read this paper? Will be able to publish it? They're like, no, they don't have time to read papers. So there has to be that very deliberate training and gaining skills on how to develop a very sound research uptake plan, so that even as the ones who are doing the implementation science, you know that the publication is not your end result, and it will only serve perhaps one group of academia. For practitioners, they probably need very short briefs. For the policymakers, they need policy briefs. Webinars for the community, for the children, you need animations and all that. So that very deliberate plan on how to develop a research uptake right from its own objectives, which might not necessarily be the research objectives, but this is purely on how to consume that data. So objectives or a research uptake plan, who the stakeholders are, and doing a mapping of them, and what materials, what products you'll produce for them once you've already generated your evidence in a scientific manner, how to break it down for the various audiences that you have mapped. So I feel like that is still a huge gap for us. We always end at publication. We always end at slide decks even when we're attending the TWQs. The assumption that because I've done it in a South End PowerPoint, everybody can be able to consume it. And now we're finding that's not the case. There's still a huge gap that we are missing with the community who we are doing this research for, generating evidence. That's a very specific training that I think a lot of us from my background require.
Thank you so much, Anne, for that. And I think that explication of the important role of the community and thinking about the community differently as co-researcher, I think is something really, really important. Monica, we're going to end this set of questions with you. If you can keep it brief, I'm aware we're running out of time. So if you could just give your quick thought on response to this, please.
Thanks. I think I'm not going to say anything too new, but I think more to think about instead of training, have more conversations. Implementers will not change what they're doing unless there's if they just get given an article to read. It has to be a process of engagement. And when we look at the research results that we're coming back, or the evidence that exists, that we interrogate it within our context, within our realities, and adjust it and work together to develop the implementation science that makes more sense to us in our context. So I think the more conversational approach is key. And then the other thing is just, sorry, to also think about specific thematic areas that emerge, and these emerge over time. And so, for example, we're finding quite an increase in adolescent suicide, and then out of COVID, high rates of adolescent or young and unintended pregnancies. These are huge thematic areas that are emerging, and more information and more knowledge around those things have become key as implementers see them and find them in the context they work in.
Thank you, Monica. And I love this thinking less about training and more about conversation and engagement, I think is a beautiful way to put that. Afsana, I'm going to hand off to you, recognizing we have 1 minute left on the agenda.
Okay, so I'll take 1 minute and you'll take 1 minute. So thank you so much, all the panelists, for your great contributions, and really appreciate it. And I know that in implementation science, we have been talking a lot about the context and the mechanism, strategies, many of the things. But as you also mentioned that, what capacities we need. From your conversation, we heard that it's so critical, and I can understand that implementation science is the integral part of the implementation of the interventions. And if you can do that, and if you can develop the capacity for our own understanding, this is, and for our own assessment, how could you scale it up, the interventions? How could you make it better for the people who actually need it? How can you make it a community-based participatory way of looking into this? And more importantly, I think the way of conversation, I think we need to have more storytelling of how could you, this is more important to bring all those things, apart from, the dissemination. How could you tell the story? Do you have to write everything in terms of publications, or you can have a storytelling? That's what I heard from a colleague from Kenya. So thank you so much for the great conversation. I'll pass it to Laura. Thank you.
Thank you, Afsana. And I just want to thank all the panelists. What a rich 45 minutes. I wish we had more time. The one thing that I'm sort of left with is this common thread of the importance of the user perspective and how we think about who the user is. And I think from what you've said, we've gotten a much better sense of that, and how we think about the community and the need for different forms of communication and engagement, and seeing that as part of the implementation science capacity building agenda. Many more things. I just want to say a big thank you. What a great panel. Thank you.
Thank you so much, Laura.
Thank you,
Afsana, for your expert moderation and the really thoughtful and provocative responses from this first panel that highlights the perspectives of implementers. We really appreciate that. And I think you've done well to set the groundwork and to put the next set of panelists on the spot in terms of how they're going to respond to this, as those that are often the ones producing the capacity development training opportunities. So since we have a lot more to get to, I'm going to pass it over to our co-moderators of the second panel, which is going to look at these issues from the research and training perspective. We're thrilled to have Stefano Bertozzi, the former Dean and Professor of Health Policy and Management from University of California, Berkeley, and Yaswa Dambisia, who is the Director General of the East Central and Southern Africa Health Community. So thank you so much to the two of you, and we look forward to this next phase of the discussion.
Yaswa, you're muted, unfortunately.
Thank you very much, Emily. Thank you very much to the previous panel for setting the stage for us. Steph, greetings from Geneva. The colleagues that have been part of this initiative from the outset will remember the coincidence that finds me in Geneva at this time, because the initial discussions around this collaborative happened in Geneva. As introduced, I'm with the EXA Health community, and I'll tease out a few issues with our next panel and leave most of the heavy lifting to Steph, because I may have to run back into the other session. But could we share the slide for the presenters? A very exciting panel drawn from research and training institutions. We have Sri from University of Indonesia, Juliana from WITS in South Africa, Andrew from Makerere in Uganda. We have Arturo from Universidad de los Andes. I always struggle with that. You'll teach me by the end of this session. And Kenneth from the University of Washington. You will say a little bit more about yourselves as you respond to our questions. But before we get into the questions, could my co-moderator, Steph, please introduce yourself?
I thank you very much, Yaswa. I'm Steph Bertozzi, and I'm at the University of California, Berkeley, and the faculty of the School of Public Health. And I've had the pleasure of collaborating with Yaswa and the HERD project since the beginning of the Implementation Science Collaborative. Back to you, Yaswa.
Thank you very much. Now, I think the panel preceding ours did set the scene quite well, because they raised a number of issues around capacity gaps, around how to frame the questions for the implementation science research, and around packaging of the products. So we shall try to get your perspectives. If I may start with Kenneth. You introduce yourself, and then you give us some perspectives on what training related opportunities, what is the training related opportunities you produce, and who consumes those products, opportunities and products within your institution, and how are they developed and by whom? Because it might touch upon some of the issues that our colleagues have been raising. And the same, I'll ask that in this first round, each of you touches upon the same question. So,
just before Kenneth comes in, I just want to mention that unfortunately we have been struck by lightning twice, because the internet is out in Arturo's hotel in Colombia, and it's out. There's a power outage where Juliana is in Johannesburg. So unfortunately, we're missing two of our moderators. They're both trying to find alternative internet to be able to connect. Go back to you and Kenneth.
Oh, thank you for that. So that then means it will be Kenneth, followed by Siri, and then Andrew. And unless Arturo and Juliana are able to find alternative ways of getting back to us. So some perspectives on the training related opportunities, how they are produced, by whom, and who consumes them.
Great. Well, thank you all for including me in today's panel. My name is Kenneth Scher. I'm a professor in the Department of Global Health at the University of Washington. We have many Washingtons. We're at the University of Washington in Seattle, Washington on the West Coast. And we started with, our department started in 2007, right around the time that implementation science as a field really started to get renowned, and a journal had just been launched in implementation science. And we started in 2011 to think critically around, well, what can we do in the field of implementation science to build on the enthusiasm for this field and try and further the methods for the global health context, recognizing that much of the work around implementation science had emerged from the US or high income country system or healthcare system. And that started with a quarter-long course for graduate students that mostly was catering towards our masters, and then quickly progressed into a whole suite of different training opportunities, including a short course which is held in the summer for 1 to 2 weeks, and then into a PhD program in implementation science that launched in 2012. And then an online 10-week course, which is modeled on our in-person 10-week graduate level course. So we have a suite of different options for training in implementation science, and they really emerged trying to target different populations. On the one end, you have a PhD in implementation science. That is, most of our students, over half, are from low middle income countries. And we have about 10 students enrolling each year. And that's really catering to people who want to devote their careers to implementation science and be active researchers or capacity builders in the field of implementation science. On the other end of the spectrum, we have a short course, which is 1 week of core didactics in implementation science held every summer. That's also been replicated in other settings with partner organizations, primarily in Kenya with the University of Nairobi. And that really caters to people who want to just understand, what is implementation science? What does it mean for me? How can I engage in the material of implementation science, recognizing that in a week you're not going to become a skilled implementation scientist who's probably going to devote your career to implementation science. So that could be for policymakers, it could be for established researchers who want to understand how they could engage in implementation science and understand if they want to have more direct linkage in the field of implementation science. And to the second part of your question, how was this created? Who created this, Yasua? Well, I mean, to be honest, we started it with a small group of faculty who were interested in furthering the implementation science from within our department. We're a Department of Global Health, so the majority of our students are from low and middle income countries. Our faculty are not majority from low and middle income countries, although we're trying to really diversify our faculty in that regard. So it did start really emerging from high income countries, but we did from the get-go leverage partnerships that we've had as faculty members with low middle income country institutions that have been developed over decades, including with UPCH in Peru, University of Nairobi and Kenyatta National Hospital, and Guatemalan University in Mozambique, and have really thought critically about how we can train up core faculty from these institutions who could then really be leaders within their own environment, their own institution, to build implementation science training and research endeavors within their own countries. Over.
Thank you very much. Siri, what is the perspective from Indonesia?
Okay, thank you, Yosua. Hi, staff and everyone. I will try to address this issue. So in Indonesia, there is no comprehensive implementation science training yet, because and also which is produced by our institution. We don't have that yet. Maybe in the other university in Central Java, which is Universitas Gadjah Mada, they might have this implementation science training, but not in Universitas Indonesia yet. So we don't have that training, like the complete one, like the introduction and then the frameworks, the strategies and adaptation, and also the study design for this implementation science. But part of the implementation science training that we have that is taught in our institution is the systematic review and rapid systematic review. The systematic review is taught as one of the required courses in both the master's degree and doctoral degree students. But for rapid systematic review, this one is taught as a short course, and this was initiated, or it was supported by HERD. This is a certificate program in Indonesia. And the participants were students, masters and doctoral students, and then alumni, and also I should say implementers, because they are from health officials. And in this short course, so this is not a required course. So this is a course that when we developed the research question and objectives, it was done together with the stakeholders. So this is a course that we do the stakeholder engagement. And we did it several times. And in one time, all of the participants of this short course were all from the Ministry of Health, because they asked us to offer this course to them. Yeah. So in terms of implementation training and related opportunity that we have in our institution, that's the situation in our institution in Universitas Indonesia. Over to you. Thank you.
Thank you very much. Before I hand over to Andrew, you didn't introduce yourself.
Oh, okay. I'm sorry. Yeah, I'm Masri Adisasmita from Universitas Indonesia. I'm a professor in epidemiology, and I was involved with her project since, I think, 6 years, since the beginning of her project. Thank you.
Thank you very much. Yes, Andrew, what are the perspectives on this from your vantage point in Kampala?
Thank you very much, Joshua. Can I confirm that you can hear me?
Yes.
Yes, we can hear you.
Thank you very much. Greetings from Kampala, Uganda. My name is Andrew, as you've heard. I direct an institute at Makerere, the Infectious Diseases Institute, but I'm also an adjunct associate professor at the University of Minnesota in the US. So the perspective I'll share is the implementation science training program that Makerere University and within IDI is part of the College of Health Sciences. Before I go into that, I'm really grateful for the opportunity to contribute to this really critical conversation, and to thank Emily and colleagues for the opportunity to be part of this panel, and also to be part of the larger project. So the implementation science training programs at Makerere and at IDI have really grown organically. And the context for this is that, and I don't think it's unique to Makerere, but when the HIV crisis happened in Africa, as it was, a lot of the initial implementation entities were based at academic institutions. So in the case of Makerere, IDI is an example, an organization that does research and training, but also is involved in implementation projects. As a matter of fact, we hold a number of implementation grants, for example, through PEPFAR and other agencies. So this is the setting in which academics really felt the need and the pressure to really enter the space of implementation science. So the program has grown organically, initially from short 12-week courses that were really certificates, and that grew into a master's level program. And now there's even doctoral level training in implementation science at Makerere, based at the College of Health Sciences by colleagues including Professor Moses Kanya. So again, to explain the context is that this has always been a needs-driven program. The initial certificate level program really was targeting implementers, so people who are running programs and really need to get skills to figure out how they can turn evidence into good outcomes. So to give you an example, Uganda has been part of networks that really generate high quality evidence. Take the example of medical male circumcision. We know that this is an effective intervention for HIV prevention. But then there was a challenge of uptake, especially among certain age groups. So you find that people who are at the implementation stage really need to be empowered with skills on how to improve demand for medical male circumcision. So it is out of this that then these certificate level programs were set out. But as the programs grew and as the challenges became more complex, there was a realization that you needed to identify faculty or graduate level trainees to take master's levels courses in this area. And eventually, now we have doctoral level programs. And some of these doctoral level trainees are actually faculty for the lower level courses. So turning to the question of who consumes these programs, really it's the landscape is, we feed into a lot of what we call the implementing partners. These may be USAID funded implementing partners, partners funded through the US Centers for Disease Control. These are really the bedrock of where our trainees come from. But as the program has evolved into more complex programs at the master's and doctoral level, we find that we're now training people who are on the Makerere faculty, for example. So I think let me keep it at that for now, and we'll be happy to elaborate further on this, as well as talk about some of the capacities that we focused on in our context. Thank you.
And Andrew, before you take a breather, some of the capacity gaps that were expressed by implementers such as Anne from Nairobi, do you have that as one of the groups of potential beneficiaries of your offerings at Makerere, the civil society and non-governmental sector, local non-governmental actors?
Thank you, Joshua. Absolutely. I believe the context in Nairobi is not very different from Kampala. So especially for the certificate, the short level courses, we get a lot of traction from civil society. Again, these are needs driven based on the implementation challenges that implementing organizations face. As we go downstream in this conversation, focusing on the different capacities we address in these courses, a lot of the discussion is around the intervention, designing an intervention that will address the specific gap that implementers need to meet. So for example, if that challenge is around demand creation, then in the short course that we provide, we really provide frameworks that address how you design the intervention so that it actually addresses the gap. So the short answer is yes, we really have a lot of trainees from civil society and non-governmental organizations.
Thank you very much for that. Taking this a notch higher to Kenneth now. could you amplify on the kind of capacities that the trainings that you offer in the various modalities focus on, and what kind of capacity development tools you utilize?
Sure. So, implementation science is unique in that it's not a discipline. It's a multidisciplinary field that leverages a lot of disciplines, and what centers it is the focus on improving the delivery of evidence-based interventions. It's also, I think we have to recognize, still a developing field where we have multiple definitions of implementation science, but one thing that is two things that are, I think, shared across definitions are the focus on delivery of evidence-based interventions and that it's multidisciplinary. So from that perspective, it's a benefit and a challenge. From a benefit perspective, if we're leveraging different disciplines, then a lot of tools are already there for training, and it's really bringing in different disciplines and reframing questions so that they focus on how to improve delivery systems. But it's also a challenge because rather than, say epidemiology, where we're focusing on really a core set of methods, implementation science is going to take us much broader. And I'm thinking at a higher level of training for people who want to dedicate their work to not just formulating and funding questions of implementation science or supporting implementation science research and embedding it into their practice, but those who really want to devote their careers to implementation science. So from that multidisciplinary perspective, thinking about, well, how does epidemiology need to be reframed to focus on understanding if an implementation strategy is leading to improved delivery of an evidence-based intervention in a very complex environment, a quasi-experimental or observational environment? Or how do we reframe the tools of organizational psychology and bring them to bear on improving organizational climate to then support delivery, or health economics to focus on implementation science? And then within this multidisciplinary field, trying to center it on questions of delivery, there are formal tools of the field of implementation science, implementation strategies, theories, models, and frameworks, and applying those to understand determinants of implementation or to guide evaluation efforts. And so a lot of our if you look at it from a perspective of our PhD program, a lot of our courses are really leveraging other courses that are out there. And then we have a specific set of courses that focus in on the formal tools of implementation science, and then reframing some of those core disciplines to focus in on questions of delivery. So, the biostats department does a fantastic job of training on individual level randomized trials. But when you get to quasi-experiments, or you get to more complex experimental designs, and then we have to be thinking about, well, how can we reframe the analytic tools of biostats or statistics to support evidence generation in the context of real world setting? So we have those courses that are core to implementation science, and then and those that build on the foundational competencies that are built through foundational coursework. When we get to short courses or courses at a master's level, we really do focus in on the surface. You can't go very deep in any of these methods in a week's time. So we really focus on getting an understanding of what is implementation science, what are the core tools, how can they be used, how have they been used through case studies, and kind of really framing priorities for the future. This year that's coming up, we're adding a second track for more advanced training in implementation science for those who have exposure to the field, to go into more depth on some of the analytic approaches and more advanced implementation science methods, tools themselves. So it really gets back to this question of again, titrating the training offerings to your audience. And so if you're going to be working with at a doctoral level, it's going to look very different than if you're working with trainees who are coming from a Ministry of Health and just want to dip their toe in implementation science, or more established researchers who want to know, what is this field and what does it mean for me and how can I begin to engage on it? Over.
Thank you very much. Aseri, as you touch upon the same area, an emphasis on the extent to which the focus of your trainings is the ministries of health as well?
Okay, thank you. As I mentioned before, that implementation science training is still very new for us, and we don't have the training yet. Maybe, but it's not that it's there is no demand for that. The demand is increasing, and it's expressed by our students as well, where mostly our students are either researcher or policymakers, or also implementers from health offices. They usually will ask us if they do an intervention study and then they have the result, what will be the next step that should be done, which would match with the implementers so that the intervention will be effective. That's many times that the student expressed those questions. So if the question is which specific implementation science related capacity are the focus of the trainings, maybe that could be the focus, which is how to do the intervention that match with the implementer so that it would be effective. But I think that we also need all the theory, the introduction, the framework, and all the components of implementation science training. One thing that also came into my mind is that effective. Effective is sometimes not very clear what is meant by intervention which is effective. Sometimes a change in a good way, but it's just at the process. It's not at the output or at the outcome level. Would that be count as effective? And if it's not effective, especially if the players are multi-groups, different groups, how would this be solved? Because this, in many times, it leads to dissatisfaction, and then it will cause demotivation. So it's like a circle of this effective thing. So that is something, if we want to hit at one specific area. But I think to do that, we need to have all the components of the implementation science training, not just at the end, like focusing on the effectiveness of the intervention. And I forgot to mention before about the opportunity. I mean, from the first question. Actually, we have a very good opportunity that we were permitted to be in Steph's course in Berkeley, but maybe we were not doing so well because of the preparation. But there is some opportunity that is a very good opportunity that we are exposed to the implementation training from Berkeley. Thank you. Over to you.
Thank you very much. I'll now hand you over to Steph, and I will unfortunately have to step out, but I look forward to watching the recording of the rest of the of this session. So thank you so much, and over to you, Steph.
Yes, well, thank you so much. As you spin away, any last comment on what you see from a regional perspective as to what is needed from the perspective of ministries of health that they would like to get from universities to build capacity in implementation science. Any final comment on that before you leave?
There is definitely the enduring questions around the no-do gap, which relates to uptake of research findings. There is also a lot of sensitivity around who frames the questions that we look into, and the ministries are looking to be more empowered in setting the research agenda. So the aspect of co-creation of the knowledge and knowledge products is definitely something that we increasingly need to look into. I think we may have the methodological competences, but we need to bring in the ultimate beneficiaries of the outcomes of these initiatives at the initial processes. I think I've made this point elsewhere, even within this collaborative, that if we miss out the inclusion of, for instance, the ministries of health, then the uptake of our findings becomes an uphill task. Briefly, that's what I would think about the need for mechanisms that will make it easier for the findings to be taken up. And of course, we have to sharpen our knowledge management skills to ensure that whatever we bring out is not only in the referred journals, but also in other digestible products, as was touched upon by some of the presenters in the first session. But so I really need to run now.
Thank you, Yasmin.
Okay.
Really appreciate your being with us. Take care.
Thank you so much, all of you.
Bye-bye. Thank you. So we have some interesting discussion in the chat. Before I get to a couple of those points, we've talked about what each of your programs is offering, but let me flip it around and say, if we thought of a more interconnected world where universities collaborate even more than they do now, certainly at Berkeley, we feel the need to collaborate with others because within the UC system, some campuses have a lot of offerings in implementation science, some have almost none. If from the perspective of your university, if you think about it in terms of collaboration with other universities, what would you like? What do you wish you had in terms of collaboration with other universities that you don't have now and that you wish you did have? Andrew, why don't we start with you?
Yeah, thank you very much. And certainly at Macquarie and at the IDI, we really need collaboration because we know that we don't have all the capacities we have. I think for implementation science, I'll raise one aspect in terms of a discipline that we feel we would benefit in terms of collaboration. And this is the health economics and being able to do robust cost-effectiveness analysis. A lot of our colleagues from the ministry, but also our funding and development partners, are always interested in, how much an intervention costs. So we found that this is an area where, we struggle to actually build capacity locally in terms of having the faculty deliver the course, but also attracting good candidates. I'll give you an example. We've had rounds where we want to train health economy focused graduates at the doctoral level. And we find that we have to compete with banks and telecoms in terms of candidates who choose to invest in fields other than the health sector. They go into business and things. So I believe that in a collaborative environment, we might be able to then attract candidates to really consider building a career in health economics and apply those skill sets in the health sector. So I think that's one area. The other area where we feel opportunities to collaborate is within the doctoral level programs, when we get to certain conceptual frameworks and theoretical frameworks that underpin a lot of the methodologies that go into implementation science, we find that you might need a partner who really has gone much further in some of the methodological approaches, and where you would benefit from sending a student to go over for placement so that they pick up a very specific methodological approach, which they will be then integrated to the work they are doing. So those are the insights from my experience, health economics, but also very specific methodological approaches that we feel we don't have in care. Thank you.
Thanks, Andrew. Asri, what about you? What have you thought about? I'm thinking. Let me just say one thing, and that is that with the possible exception of Kenneth and a little bit of the programs that Andrew's discussing, we collectively as universities meet very little of the potential demand out there. And for example, even the universities that have the biggest programs for non-enrolled students, I suspect that nobody has a program in Bahasa Indonesia that reaches members of the Ministry of Health in Indonesia, which is a huge country. So I'm curious, have you thought at all about how these kinds of collaborations might create training programs which could be very high quality, translated into multiple languages, and co-implemented by a network of universities? Have you thought at all about things like that might meet a much greater proportion of the demand we presume exists outside of the university? And we should also talk about the demand from our students, but I'm thinking first just of the huge demand I imagine might exist in Indonesia that nobody's meeting right now.
Yeah, thank you. Yeah, that's actually a dream if we can have a collaborative course that both in Indonesia and then with international partners. And the one that's tailored for the Ministry of Health and also district health offices and provincial health offices. We have 34 provinces and I think about 500 something districts. So actually, if Universitas Indonesia and maybe with several other universities in Indonesia can have this a strong program, or the faculty members can be capacitated, and then we are going to be good in implementation science, and having that, I guess we are looking for a collaborative training with your institution, with Kenneth's institution and the others, so that we can leverage our knowledge and capacity, and then us can, like what you said, maybe translate the modules into Bahasa Indonesia, or maybe in some still using the English, because if we want to do for district level or for provincial level, some of the provincial level could use the English. That would be good, but yes, for the majority, it should be in Bahasa Indonesia. But for the Ministry of Health, I guess English would be also fine. So if that could be happening, that us could be a sort of a center for delivering the capacity for Ministry of Health and also health offices, both provincial and district. That would be wonderful, and also collaborating with other universities in Indonesia, because Indonesia is a very wide country. So maybe we can have on the west side, on the central side, on the eastern side of Indonesia, we have several central for implementation science training program. Thank you.
Thanks, Asri. Kenneth, if UW is similar to UC, our programs are pretty expensive, and we, do get some donor-funded participation, or people who happen to have resources who are able to participate and who sometimes leverage that into credit for other degrees or whatever. But the cost itself is a major barrier. What do you see as a path forward where institutions like yours, through some sorts of collaboration, could actually, quantum increase the volume of students who benefit from the course development work that's done, but not delivered through the mechanisms, the high cost mechanisms that are currently the ones that we use? Have you had thoughts about that?
Yeah, I mean, it's a great question. And take on the one end of the spectrum, PhD programs, well, that needs to be intensive. That needs to be high degree of mentorship, and that model is not easily scalable. The reality is there are hours and hours of recorded lectures on the web, and you can go to places and find those, but it's not really going to be curated. We do have a distance learning course, which is 10 weeks, and we're able to enroll individuals as well as individuals in a site model. It's relatively inexpensive, a couple $100 for 10 weeks of training, and it goes through the core elements of implementation science. It's all in English and requires a decent enough web connection to access it, but it is one model that is more accessible. I did want to briefly mention a collaboration that happened between 4 Sub-Saharan African and 4 US universities called the AFIA Bora Consortium. It was funded through NIH, I think Office of AIDS Research. And it was a one-year fellowship program for primarily Sub-Saharan African trainees, as well as a few US-based trainees, where there was a didactic and practice component over that 1 year. And it's one of the few opportunities or examples that I've seen of such a large number of academic institutions coming together into one training program. And it takes intent and it takes funding to make it happen. But there are examples that are out there. Steph, I think it's speaking to your question of, is there a way that we can build a network to offer training and in such a way it's going to be most relevant for our end users?
Yeah. Andrew, I was struck, in the sort of engineering of this seminar, we had the first panel that focused really on what implementers need, and then the second panel is of university partners. And we didn't get to a very clear articulation from the implementers of what they need from us. We got quite a general sense of what their needs are overall, but translating that into marketing assessment of what they need from us, I think will still take some work. So I'd like everybody to think a little bit about what we might do collectively to better understand our market outside of the university, and similarly our market within the universities. What do our students need from us, and what kinds of students need what? But just while I plant that seed, I want to come back to this message from Colin Boyle, because it's actually something that I've been thinking about for years and years and years. And that is, for those of us interested in improving implementation, it's been remarkable to me how little the health sector has engaged with universities through their business schools, right? As opposed to through their medical schools or public health schools to focus on implementation. And why has it been so difficult? You know, what Colin mentions is that behavior change looks a lot like what people do in marketing, and quality improvement looks a lot like what people do in operations management. You know, good management practices is a core part of what we do in implementation science. And why has it been as difficult as it has to get that part of the university involved more substantively in what we do? And I'll offer one thought about that, and that is that I think the world of implementation science in Europe and North America is quite different than it is in global health. And partly that's because the US model of implementation science is more about diffusion of technology, and the implementation science model globally is more about efficient, effective coverage. You know, how do we achieve scale with our interventions? And the global version draws more on business practices than the domestic version does. Maybe that's part of it. But I'm curious, Andrew, just because Colin put that in front of us, you have a business faculty at Makerere. How much are they involved in the work that you're doing? And why do you think, if it's not as much as you think it should be, why not? And I'll ask the rest of you the same question.
Thanks. Very intriguing question. And, you know, I'm ashamed to say that they're not really greatly involved. And I think it's both a supply and demand issue. What I mean is that we in the health sciences have not engaged directly with our neighbors, because in the case of IDI, we are actually on the main campus of care. So we have a great opportunity to just cross the street and initiate these conversations. But also, the business school has also not been keen to say, you know, is there room for us? And so we have work to do. I have to say that I think in universities, maybe not in the global South alone, but overall, we tend to be siloed, if we're honest. You know, people in their areas of work and put their head down in the trenches to work. And I think for the health sciences, I'll even give you an example. This concept of One Health, where we recognize that pathogens don't respect our discipline boundaries, whether you're a human or an animal or the environment. And so the One Health movement is trying to force us to work together. And I have to say, in Uganda's experience and many parts of Africa, we've really struggled to get the medics to talk to the vets and to talk to the environmental disciplines, to really think about this in a wholesome way. So you can see that even within the health sciences, collaboration does not come easy. So extending that to the management sciences can be a stretch. But I think there are rays of hope. As I mentioned, the area of, for example, health economics is something we've been trying to really build some bridges with the economics disciplines. You know, and I'll even cite one example that we have tried to kind of borrow from the business world, which is adherence to medication. So in the HIV space, which is my traditional area of infectious diseases, is we need to get people to take a pill every day. And it can be a daunting challenge. But then you figure out that the people who make toothpaste have convinced us to brush our teeth every day. And so what can we borrow from that whole experience of marketing toothpaste as a product that is used every day? So I really think there are real opportunities. And I think I leave this conversation enriched to really think about how we can build bridges. Thank you.
Thank you. Asri, what about you? You mentioned that you don't yet have implementation science courses. And in full disclosure, Colin is a colleague of mine who works at the business school at Berkeley. So it's a nice to have that challenge come from him. I might say, well, there's some courses at your business school that are very relevant. What do you see as the potential there?
So working in collaboration with the business school. Not in implementation science, but our School of Public Health also have collaboration research, especially with the business school. Yeah, we have collaborating in terms of tobacco smoking research, and then in tuberculosis. Many of us are collaborating in those topics, and also in health economics. We are also work together. Yeah, but I guess it's very possible that we work together with them, because in our business school is actually an economic and business school, faculty of economy and business school, and under that school also they have demography, and that demography is also very related to health. Many of the faculties there do research in public health, so it's not something that's remote, that we can work together with the people from the business school.
Great.
Thank you.
Ken, we are down for our last 2 minutes, so can you take us home and just share a few last thoughts?
Yeah, it's a great question. When I was talking about methods from different disciplines being applied to salient delivery questions, this is a great example. And within our framework of methods that we focus on, we include operations research, but really from that industrial and systems engineering perspective. So applied mathematics, simulation optimization modeling to help decision making, social marketing as a demand generating tool, organizational psychology. How do you assess, understand, and improve in terms of an implementation strategy, how organizations are functioning? But we don't really do this with the School of Business as much with the Department of Industrial and Systems Engineering. And I say that because our major barrier of taking courses in the School of Business is that it's a different business model. It costs a lot more to go to take courses in the School of Business than in the health sciences. So we're working with faculty with similar skills. And really, I think the great question that always comes up is, how does this material apply for improving the functioning of delivery systems in the global health setting? And a lot of that is engaging with faculty over years to come up with joint research, to provide examples, and to really take tools that may come out of a discipline and apply it to specific questions that are most relevant for improving health at a population level.
Thank you. Thanks to all three of you. I'm sorry that we missed our other two panelists, but I think in exchange, we got more out of each of you. And thank you also to Yaswa, who had to leave us. Emily, it's back to you, I think, on time. Thank you all again.
Thank you so much, Steph, and thank you to all the panelists. We really appreciate your inputs. We are going to take a quick 10-minute break and reconvene promptly at 11:05 Eastern, so 10 minutes from now. While you're on the break, we're going to redeploy the poll from the beginning of this session so that we can capture those who did not participate in the poll at the beginning. And secondly, we are going to share the link to the preliminary scan of resources. So you can have a look there at what we've found so far and follow up with any comments via email, or you can put some comments in the chat if you'd like as well. So 10-minute break, and we're really looking forward to building upon these sort of implementer and research and training perspectives and kind of put it together with a conversation about collaboration specifically and how they're advancing implementation science capacity. So don't go away, but please take a break and we'll see you in 10 minutes. Thank you. Hello, I'd like to welcome everyone back. I hope you had a good quick break. Glad to see that you are still here with us. As we prepare for the final panel and the wrap-up discussion, I'd like to have us share the results from the poll. So if my colleagues could pull that up, that would be great. Just to kind of give some context to the composition of the audience, you can see here, as predicted, the majority are from research and training institutions, but we have a fair number, and those who do research primarily, but we have a fair number of those from service provider or program implementation backgrounds. And only one who identified as policy, knowledge management, and communication. We had some students, one who focuses primarily on training, and a few who identified as other. So just to keep this in mind as we move forward. And I think we had another poll. Have you participated in training that is focused on implementation science? So the majority have not. It'd be interesting to kind of understand why that's the case. Many of us have learned by doing, or may or may not have had access, or are looking to engage in these types of trainings and have not yet done so. I hope everyone was able to access the link in the chat with the preliminary scan results. We look forward to your feedback and amendments on that. And now I think we don't want to take up any more time before we jump into our third panel. We're very grateful to have two amazing moderators for this panel as well. We have Rosemary Moisaka, who is at the East Central Southern African Health Community, and Vicky No, who is at the City University of New York. So I will pass it over to Rosemary and Vicky to introduce the panelists and take it away. Thanks so much.
Thank you, Emily. I'll start us off, and Rosemary will help lead the discussion after the panel presentations. Thank you all for staying, to the third panel. We're really excited to have this great panel discussion that's going to be focused on reimagining the science of collaborations for implementation science and how we might enhance collective capacity through partnerships. We've heard a lot earlier about stakeholder engagement and what different stakeholders need for implementation science advancement. And then we've also talked a little bit about training models for implementation science. And so this session is more focused on partnerships and collaborations. And we all know that collaborations and partnerships are a very common strategy used, implementation strategy used for moving the field forward, in terms of advancing evidence-based practices or interventions in the real world. But we're also increasingly using it to advance the field in general, to disseminate information and knowledge about implementation science and to engage more in the process of advancing implementation science. But we don't know a lot about what features, what components, what qualities of collaborations make them effective. We don't know that much about what sorts of outcomes we should be paying attention to when we're thinking about collaborations and coalition buildings and what we should be working to achieve in these partnerships. And so today, we have this great panel that are involved in various large collaborations, many of which are multi-country, multi-regional partnerships across a wide range of stakeholders that focus on implementation science capacity building or advancing the field. And we'll hear from their experience. We'd love to hear some lessons learned about what features, components, qualities of the collaborations you all are involved in, and what makes them work, and what can we learn from that. And with that, let me introduce our first speaker, who is Dr. Rachel Stirk, who's the Acting Deputy Director for the Fogarty International Center. She is also the Deputy Director and Senior Scientist in the Division of International Science Policy, Planning and Evaluation, and the Center at the Center for Global Health Studies. Dr. Stirk is an expert in implementation science. She oversees a portfolio of global projects that include focus on building research capacity in implementation science in low and middle income countries, using innovative platforms to bring practitioners, decision makers, and program implementers together. She's engaged in work across LMICs, extensive work in India, Ecuador, Peru, Sub-Saharan Africa. She's also an active member of the NIH Dissemination Implementation Science Working Group, which leads NIH working, which leads the Trans NIH Working Group focused on building capacity in the field. She co-chairs the NIH Annual Conference on Science and Dissemination Implementation. So she brings a wealth of knowledge. She'll be talking more about the NIH Fogarty Adolescent HIV Prevention Treatment Implementation Science Alliance and others at NIH. So please take it away, Dr. Stirk.
Thank you for that introduction. And can you hear me okay? Yeah, okay, good. Thanks again for the introduction. So I was going to be talking about one of our flagship projects at the Center for Global Health Studies. As Victoria mentioned, I do lead a portfolio of implementation science projects and sort of catalytic work across NIH. But this particular project lends itself well to the focus of this particular session. So the Adolescent HIV Implementation Science Alliance is really premised on the idea that bringing end users, which we've heard a lot about today and have gotten great perspective on, together with our NIH-funded researchers to really create a space for bidirectional learning between these stakeholder groups. So at NIH, implementation science itself has taken kind of a long time to get traction in terms of it being a sort of valid science. And so it's also not conventional for us to be pulling in the end user. That sort of last mile is not the space that we typically incentivize. And so when we started this project, the idea really was that implicit in the sort of science of implementation science, we really need to bring in those end user groups in order to extend the reach and strengthen the work itself. So the network itself, which we call an alliance, is made up of 26 teams, and the teams themselves are supposed to be sort of embody this idea of bringing those end users into the scientific process. And so the teams themselves are an NIH-funded implementation scientist, and then their in-country counterparts, which can be researchers, but we've encouraged them to be policymakers and program implementers. And the teams are working across 11 countries in Africa with a focus on prevention and treatment of adolescent HIV. The goals really are, again, to create this space for cross-fertilization of ideas, to enable the research to be better informed by real-world challenges and implementation challenges on the ground, and then to inform policymakers and program implementers of evidence in real time. So really to create that space and sort of the nexus that allows for learning and communication. One of the key pillars of Fogarty's work, I think it's important to mention, is capacity building itself. And so that is a sort of very embedded feature in the AHISA platform itself. Interestingly for us, even though some of the PIs are funded implementation scientists, we've had a lot of grassroots requests for more training in implementation science. So we have done a lot of training of the network across its, we're about to have our 7th annual meeting. And all the way from sort of small sessions that focus on specific pieces of implementation science or stakeholder engagement, all the way to a full 2-day commissioned short course training in implementation science. And I think one of the challenges that we have come across and has been part of the dialogue stemming from the work of AHISA is sort of how to capacitate a group of researchers, policymakers, and program implementers together, and whether and how we do that. What are the capacity needs that are different between those groups, and how do you sort of create a space for learning that is accessible and meaningful to all those groups at the same time? And maybe that isn't possible, but that's a question that we've been grappling with. Importantly, and you should give me a hand or something, Victoria, if I'm running out of time. But just to say, one of the things that we've also really focused on with respect to capacity for implementation science is creating locally led networks themselves. And so we are kind of working across 11 countries. We're grappling with sort of transcontinental issues around implementation and implementation science. And what we've tried to do is create, we've provided some very small seed funding for some of our alliance members to create national or regional, basically mini alliances. So really that grapple with locally grounded implementation challenges and really think about the implementation science agenda for a country. We have one that's regional in West Africa. And the idea there really is to plan for sustainability and to create space and opportunity for capacity building at a local level, and to create also the opportunity for collaboration that's locally grounded. And our thought there is that that will create sort of a sustainable pipeline of capacity. I should say that we are right now doing an evaluation of the AHISA project overall, including those smaller networks. And I think we'll learn a lot from sort of what's worked, what hasn't. Each of those smaller networks are really different. We've let them create sort of their own model. And so one thing that'll be great from that is that we'll get to understand kind of how the different models work. Some of them are very connected to ministries. Some of them are very academically grounded. So they're all quite different, but all of them prioritize capacity for implementation science. And I guess I'll stop, but just to add one more note that's come up a lot in all of our work is around the idea that there may or may not be a critical mass of implementation scientists. And so we're missing opportunities for mentorship. And so sort of a lot that sort of architecture of capacity, I think, needs bolstering based on what we've heard from our network teams. So I'll stop there, but I'll put the AHISA link in the chat and happy to answer questions.
Thank you, Dr. Stirk. That was really great. And actually, one of the questions that you raised, I would like to raise later on regarding the challenge of training diverse stakeholders together in a meaningful way. So I really appreciate you raising that. And thank you for sharing about like the importance of localizing some of this work. And we look forward to hearing more about the evaluation that AHISA is doing so that we can learn more about the lessons learned. Now to our next speaker, we have Dr. Sabina Rashid, who is a professor as well as a dean and director of the Center of Excellence for Gender, Sexual and Reproductive Health and Rights at the James P. Grant School of Public Health at Brock University. She also founded the center, founded the Center for Gender and Sexual Reproductive Health and Rights at BRAC and co-founded the Center for Urban Equity and Health. She's led several multi-country research capacity building grants with the Institute of Development Studies, University of Sussex, Liverpool School of Tropical Medicine, London School of Hygiene and Tropical Medicine, and a number of other universities and institutes. She's very accomplished and has been a member of numerous national, international committees working across a variety of science working groups, WHO, the Wellcome Trust, and has been involved in a variety of different global initiatives and collaborations to support implementation science. And so we look forward to hearing from her and some of her experiences. Lessons learned. Hi, Dr. Rashid.
Hi. Just call me Sabina. A very generous introduction. We have some meaningful partnerships, some equitable partnerships, some meaningful partnerships, and I'm not going to focus on the ones that work. I wanted to kind of put out some critical questions. I'm a medical anthropologist by training, so I'm not sure if I fill the implementation scientist sort of hat, but I think we all end up playing a role in implementation if you live and work in spaces that require you to either translate through teaching or research or working with many actors. So one, I wanted to say there's a conundrum we have where when we say stakeholders and we talk about professors and then we talk about local communities, there's an automatic hierarchy. And there's a hierarchy of a presupposition of particular kinds of knowledge and who brings what to the table. And I want to kind of challenge some of these hierarchies, because I think Rachel explained it really earlier quite well about linking in with partnerships and working at a local level. But even with the global and the local, I think it's useful to kind of question and interrogate what those meanings, what does it actually mean when you're working with partners? Why do contexts matter? Why is embedded long-term engagement required to build relationships that have sustained kind of ownership that allows for adequate, appropriate practices or translations to take place? Otherwise, it's the quick and the fast, and sometimes communities or certain stakeholders are not often included throughout a process, but are brought in at different times that are convenient for us who work in academia, or even in terms of co-developing or co-designing courses. I mean, usually what happens is, in my experience, we've actually worked with colleagues and we've co-developed, co-designed practical competencies that are required, let's say in sort of, I don't know, health systems or reproductive health language or service delivery and messaging. But I've often come up against a sort of explicit hierarchy where an implementer may not be considered as valuable as a faculty or as an academic. And somehow a PhD gives you some sort of a know-how about an entire environment, context, place, site, along with the ability to implement. And I think we need to kind of interrogate those assumptions, which maybe many are, but I still feel at some levels it persists. And then we've got communities, and there's an inclusion, and sometimes it can be an inclusion of what kinds and who are we talking about? Most affected? Are we talking about community leaders? Are we talking about those who are off the margins? Are we talking about a continual feedback loop, assessing the kind of implementation and the training and reviewing what is the levels of uptake of some of these discussions, even retention. How much does it resonate and could work? Because a country in itself is very diverse and has many different, and looking at what kind of training for whom and for what, and recognizing its own limitations and strengths within that. And finally, I really wanted to say that when we work in developing countries or across countries, I don't want to make it about north, south, 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 north, east, west, but it's really about a particular mindset. Like, what is the mindset we bring in? Me sitting in Dhaka, and I decide to, delegate certain responsibilities to my colleagues, but I myself sitting in Dhaka by my location doesn't make me contextually any more sort of knowledgeable. So I think at every level or wherever you're located, it's more the mindset and the aim of the implementation, and realizing these are messy spaces we work in. The politics, the social fabric, the economics, the vulnerabilities. COVID showed and lockdown showed how some things just didn't work in settings. And we needed more nuanced and much more carefully thought out measures, which are primarily, at least in Bangladesh, very clinical task force. So, to jointly co-produce, co-write, have voices that are multiple, to acknowledge one single knowledge bearer, but actually implementation is sort of just like anything, and you work in research or teaching, at least in my field, it's sort of lifelong. So you have to constantly reflect. And that was just some of my initial thoughts. Thank you very much.
Thank you, Sabina. Thank you for reminding us about how context matters, and that we need to be aware of those power dynamics and the hierarchies, and what we bring to the table in terms of being part of these collaboratives. We will continue that discussion after we hear from our third speaker, who is Dr. Vikas Dwaveldi. I hope I pronounced that correctly. He's the Health Information System Advisor at the Palladium Group and a co-chair of the Digital Data Working Group of the Health Data Collaborative. His work focuses on supporting health systems at the intersection of health data, digital, and data use. He's worked with with various country health systems to improve data and digital governance systems and support interventions across data value chains. So he, will be talking more about the Health Data Collaborative Digital and the Data Governance Workgroup Collaborative Model, what's worked, what's been challenging for that model. Please take away, Dr. Doveldi.
Thank you, Vicky. It's really call me Vikas. It's okay. So good morning, good afternoon, or good evening, everyone. My name is Vikas. Joining you from India. Really listening to this interesting discussion and bringing a slightly different flavor from not so much core implementation science, but definitely heavily involved on the implementation side and capacity building. Not as a professor, but more of as a hands-on trainer, and bringing and building capacity for day-to-day activities. So I am with the Palladium Group as a senior health information system advisor, and at the same time I co-chair a working group that's focused on digital and data governance. And this is the working group is under the Health Data Collaborative, and the Health Data Collaborative has in total 7 working groups, so it's kind of a network of different topical areas that have formed working groups together, and they work on diverse separate areas, but also how they come together around supporting data systems at the country level. So specifically about the working group that I lead on digital and data governance, it has been around 2 years that we have been I've been engaged in setting up from the beginning, and I think some key lessons learned in that is definitely it's as part of the working group, it's one key lesson that I can say setting that up and making it functional is the understanding that it's collaboration for a purpose. So the group has a purpose identified, or it could be multiple, but the purpose is clearly defined and agreed upon by the members. So that's kind of very essential. And as part of that, what we've been able to do is we have, on one hand, successfully established some health data governance principles that were non-existent in the past. So it came up from really from a human rights perspective, and we follow a bottom-up approach, talking to countries and really hearing about what the challenges are around data governance and data issues around privacy and confidentiality as examples, and what should be the a global architecture that needs to be in place. So in that process, we engaged around 200 different organizations, civil societies, ministries of health, through that collaborative process, and boiled them down to the areas that were essential, and identified a set of principles that have now been endorsed by over 100 organizations, which are constantly working in the health sector and collaborating in improving the data at the country level. So that's kind of one way of how the principles were designed following a bottom-up approach, and really the organizations have come up and endorsed it, and they are now using that in their implementation at the country level. The second example is, and this is a couple of years back now, through another network that I'm actively engaged, is called the Open Health Information Exchange. And we, a set of partners came together and identified a need for the building capacity in interoperability and data exchange. And so we collectively through working groups, came together, designed a full academy or a full set of curricula around health information exchange. And that we brought in, as a local university partner in Ethiopia, a university that we brought in as a partner and worked with them. And to date, that academy is being running at the Ethiopian university and has been training students as well as professionals coming from the region in Africa. So through just kind of that collective partnership, we were able to design. Of course, it's not a PhD level curricula, but pretty much hands-on, providing basic sort of understanding and know-how of what health information exchange is, and it's been running successfully since the past 2 years. So I think again, sort of coming back to the issue of capacity building and really bringing, managing these global working groups. We have around 70 members that come from different organizations, including donors, implementing partners, Ministry of Health representative, and implementing partners who were really working at the grassroots level, and really trying to bridge sort of not just having a top-down approach, but also having a bottom-up approach. That what are the gaps existing at the grassroots level, and how we can bridge that, and bringing the know-how from the global expertise that we have. Again, no north, south, east, west, but collectively how we can solve those issues around building capacity, as well as other areas that we have been able to collaborate and work on. So I think that's just kind of an example of how we are managing the working group and the partnership around these 70 plus organizations, and identifying sort of, I think what I mentioned earlier, collaboration for a purpose. So identifying the what is really critical, and identifying who's knowledgeable about that and who can contribute and who will be the beneficiaries of that, and sort of trying to bring that sort of, teams closer to each other and work with them. So let me pause here and hand it over back to you and take it forward. Thank you.
Thank you, Vikas. That was really great. Great example of how collaborations are applied, to a specific area in terms of data sharing and implementation exchange, technology exchange. So that's really wonderful. I was just wondering, is that resource available in terms of the curriculum, for supporting folks to be active and inform users of data system exchange? That would be wonderful if you can share that link for the rest of the group, because I think that applied many of the partners and folks in this meeting. So now I'll pass this back over to Rosemary to lead us in a discussion. Rosemary? Oh, I think she's having some connection issues. Okay. Well, I guess while we wait for her, I can start us off. So, we've heard actually, quite a bit from a range of different experiences. I was just wondering if each of you can speak to what's been the, most important consideration in terms of building an effective collaboration for capacity building, particularly for diverse stakeholders, because I think all of us work in collaborations and partnerships where there are lots of different types of folks. And so what, do you think are the most important things to consider, in terms of building capacity? Maybe we can start with Sabina. You mentioned a few things earlier, and then we can go from there.
Yeah, sure. I was going to raise my hand, so I might as well.
Yeah.
I think, there's a lot of ways of strengthening or having good partnerships. We work very well with CUNY, actually, we just co-developed and co-designed health informatics with Liverpool School. There's many other partners that are really in the principles of equitable and very, very sort of collaborative approaches. I do think it's an ethos, what I find, It's an ethos of respect and humility. I mean, it's a very human kind of element, but I think if you have respect and humility to know, I know this or I don't know this, and what are the kinds of engagements I need to do, or who are the right people I need to bring to the table. I also think to acknowledge failures and discuss those openly are good elements, because I think failures often teach us how to improve and strengthen. Those just off the top of my head, I do think they're very important given the kind of work we do.
Mhm.
Ethos of respect, acknowledging, and also talking about failures along with the successes, I think, that are important.
Thank you. That's great. Maybe Rachel and Vikas, any others?
I would just say, I think creating space for listening, I feel like has been really helpful for us, without a huge agenda, so that we're making sure we're hearing from sort of everybody in an equitable way. I think one of the interesting spaces in the world we're working in with adolescent HIV is how to engage and capacitate adolescents and youth voices, which I think it is an interesting exercise. I think we have space to grow there, but also thinking about how to capacitate them in the implementation science space has been challenging and interesting. But I think, again, just creating the space to hear what needs are and what questions are critical for each group is really important.
Mhm. What has been the more effective strategies for creating space? And how do we create that space? Because often we have these meetings, but does that really create space?
It's a good question. And do you hear from the loudest people in those meetings? But I think this is a tiny example or a tiny tool, but I think for us, we've made sure to create time on the agenda and or outside of the meeting for without a lot of programming, so that we're really hearing from the collective group, which includes all stakeholders, what their needs are and how we can best support capacity building. But I think you're right, we're often like scurrying through an agenda, and it makes it hard. But
yeah.
Yeah, I think just to add to that, that's a very valid point in terms of creating that space. Just from a perspective of managing multi-agency groups, working groups, and sort of building on what I said earlier in terms of collaboration for a purpose. It's the aspect of how the whole sort of group is governed and managed is really critical, and much of it now we have, all of us, I think we have some flavor experienced online working and digital working, right? So using those tools, how best we can reach out to everybody. Not all like I said, 70 plus members are part of the group. Not all 70 members join those working group meetings, right? Some join some meetings, some join in other meetings, but having the governance of open communication and sort of openness about what was discussed and sharing that with the larger team, even if they were not able to join, having collaborative documents that people can, if some people are not sort of that active on calls and meetings, but at least they have access to the document itself and they can go and comment. I think are some ways that we have sort of tried to manage, but at the same time, reaching out sort of separately or individually with these groups and checking, making sure that yes, this is really responding to the needs at the ground level. So whatever we are creating is not just sort of for the purpose of it, but it's really helpful for the implementation and supporting the work at the country level. And subnational levels. I think that's essential level as well. So yeah, just to kind of keep that, keep us on track. So yeah, I think that's just kind of a lessons learned around managing this sort of groups together and really coming out of a desired product that can be then implemented and used.
Rosemary, if you want to take it from here now that you're back.
Yeah, thank you so much. Thank you, Sabina, Rachel, and Vikas. I think it has been a very interesting discussion. So far, so good. And maybe just a follow-up. I think you have highlighted very important points, maybe which we need to take on board, especially when it comes to partnership and creating space, the essence of communication and having the common vision and so on. But maybe just as a follow-up question, what has the collaboration you've been having so far, how has it enhanced the implementation science capacity? And what role has the capacity development played in developing the partnership? So maybe you can start with Rachel and then come followed by Sabina, and then Vikas can finish to respond to this. Thank you.
It's a really good question and an interesting one, and I don't have like an answer, but I would say that the network itself, because it is fostering collaboration, both sort of the teams, sort of at the micro level and then across teams, I think we have been able to understand what the gaps are in capacity collectively. So not just from like a researcher perspective, but from a team tackling a global health challenge perspective. And I think with that information, we've been able to then sort of do the listening and then come back and bring in experts who can speak to the challenges that the network itself is identifying. So it's sort of a self-perpetuating strengthening of dialogue and communication. And I think similarly within the smaller networks, the more locally grounded networks, I think they're creating that same kind of collective thinking and understanding of what capacity needs there are. Again, very differently with each of those networks, that whether it's at the ministry or within academia. So I think it's just been really embedded in kind of the problem solving that the network itself is doing. And we've supported it and sort of elevated that as a priority. So I don't know if that answers your question, but I'll stop there.
Yeah, Sabina, can you share your reflections?
Are you asking about how do we keep a certain kind of ethos in our partnerships based on what I was sharing? Rosemary, I just wanted to clarify what you were trying to ask. Is that what you're asking?
Yes.
Yeah. So, I mean, I think I'm lucky because when I came to Bangladesh, I was 23. When I joined the School of Public Health that was set up by our late founder, Fazil Hassan Abid, it had a certain ethos. It was about communities, communities, communities. So whatever we did had to directly translate either through very, very experiential-based learning, teaching, beyond theories, contextualize and adapt. You have to be inclusive. We've always had to work with stakeholders, or let's just say multiple actors who inform the kind of research we do. And at a national level, it just came in a space where we had to learn very quickly. And, you know, when I joined the school, we were 6, we're 200 now, but really it's a multidisciplinary teams. But I think one of the advantages when you work in a space where the ethos was, it's all for community. So how's it your teaching and learning teach students to be mindful that policies or programs are making a difference or not? So what are those challenges? So we have lots of discussion around case studies. In terms of research, we have to actually activate or work in that space. We house a civil rights group, a civil watch group. So a lot of our information has to kind of be, so what is its sort of impact is a weird space to be in. So how about like, how far are you reaching, who you're trying to reach, who's your audience? We've also been fortunate, other than some challenging partnerships, we've also had some extremely, very, very strong, meaningful partnerships with many, many institutions and individuals around across the globe. We're also very, very aware, either have long-term embedded engagement. So when you have certain principles sharing mean, are we talking about capacity building or do we call it capacity sharing? And at sometimes it is capacity sharing because you're learning from each other and no one is sort of, of course you have the methods and technical expertise. I'm not discounting that. I would be stupid to discount that. But, when you change some of the language, it also kind of pushes people, including myself, sometimes to critically reflect about my assumptions and biases. So some of the ways I think is of the way we were founded, but also trying to keep that going in spaces where it's not always perfect, but it's a work in progress. And I think partnerships, whether it's within or across, we have to reflect on how do we improve and trust is very important over time. And what are those aims goals that Vikash was also talking about? Get places, get work done, keeping those in mind, if that helps. Thank you.
Thank you so much. I think I agree in that concept of saying that capacity sharing, taking into account that everyone has the capacity or some knowledge or know-how which might be not known to another person. So let's hear from Vikas.
I really like that term, Sabina, the capacity sharing. I think I'll start using that more often now. So I think the aspect. So one is like coming back to the working group. We have been how we work together is have monthly coordination meetings and definitely check in over emails and share ideas and approaches over emails. But using that sort of monthly meeting platform is also providing not just for working on products, but also providing that platform for sharing what is happening, and also creating that learning network between implementers and between countries and ministries of health and the community basically. The one thing I think Rachel and Sabina definitely covered. I think one thing that what we also use a term and as part of the process in technology development is testing. I think that's essential that when we are developing these new sort of material or new approaches, or I think we should get down and test them out with the real users and make sure that it has that we plan for it and it happens, that we are really able to put it on the ground and really test the waters, that it is really responding to the needs or not in terms of that capacity sharing approach, and then I think refining based on the comments that we receive. So we should not be shy of testing these curriculums, approaches that have been developed and refining them and making sure that it responds to the needs of the community or the where it's really should be implemented or used, even if it is research or implementation. So yeah, I think that's just to add from my perspective.
Mm-hmm. Great, thank you so much. Rosemary, I think you're muted.
Yes, sorry, I was talking to myself. Thank you so much. Unfortunately, we are really running out of time, but I think it has been a very interesting discussion. And at least from your answers, we have really managed to see some of the key issues when we discuss about the partnership. It's one thing just to come together, but communication from Vikas, I think it's very critical. Everyone should be on the same page. And I like this, the concept of capacity sharing, not really undermining that maybe you think that maybe you're superior, understanding the hierarchy between the team, and knowing that who are we addressing, the community or the key target group we should be addressing at. We should also not undermine them. We should just we should not see that maybe we are solving the problems, but maybe they might be having their own research capacity, the local one, which might be adding value to the great work, which is more maybe structured. So thank you very much also, Rachel. And I think that the work which we are doing and the capacity strengthening initiative which we're doing and looking at the sustainability aspect, how you engage the locals, and making sure that everyone is on board is quite impressive. So I think maybe in another time we'll have more opportunity to learn and build on how can we strengthen the implementation science partnership as well as collaboration. So back to Emily.
Hi, everyone. Thank you so much. We are just thrilled with the richness in the conversation. And as we have about 10 minutes left, I'd like to invite any of the moderators and panelists who are still here to put their camera back on and be willing to share any quick and final remarks. I also invite anyone in the audience who's still with us to share any sort of major takeaway message, something that really resonated with you in the chat, or a question that this conversation has left you with that you'd like us to take up in future conversations. And so as I invite my colleagues to join, I also would like to give Dr. Jim Sherry, who is the HERD project director and professor at CUNY, an opportunity to also say a few remarks and provoke us at the end of this productive session. So if my colleagues could put their cameras on and join, that would be great. Thanks so much.
Oops, were you asking me to start?
Go
Okay,
ahead, Jim. You can call
there's no way to summarize such a thing. This has been extraordinary in my view. I did text Emily during to be sure that this was being recorded because one, I have a short list of people I want to share it with, but I want to see it again myself. There's just so much here to be unpacked. But right through, I think again we hear differently based on how our ear is tuned. But I was struck that with Afshana starting it with her friend Laura and from the work they had done together, but in the beginnings of this, when we were wrestling with this concept, Afshana at that time was, she was the director of health for the largest community-based, health program in Bangladesh, but I think maybe, almost in the world. It was just such a huge and dramatic thing. And I sat with her once and trying to get a handle on implementation science and asked, what was the problem with kind of making better use of research? And she pondered for a moment and said, the problem has been is that, yes, we have resources available to us, and we ask them questions, but by the time they get back to an answer, we've had to move on to the next question. And so I thought that just, that kind of captures what we do. And if we look back just these last couple of years, it's like, wow, that's relevant. And where we saw great progress in this past pandemic, it was with people. I think Anne was getting us to get the local documentation, what, not necessarily what works, but what seems to work. And that may be a lower standard bar for us as we have our research hats on, but maybe when we're trying to get things done, that's the appropriate bar. And, kind of finding that, moving that to then also the research community to move the seams out of it to what works. So again, so many themes here, for me, a part of this effort has been the, democratization of science and all that means. And it's not about voting for what's the best, intervention or the best vaccine. It's about, I think, breaking down some of those barriers that have been talked about and those themes that have been just, kind of discussed, whether it's, yes, using the frameworks and the theory and the methods, but not letting the rigor overpower the relevance. And some of these ethos issues that were raised, I think so importantly, about listening without an agenda and respect and humility, which, as scientists, whether we're practicing scientists or whether we're research scientists or whether we're implementing scientists, really is, should be part of our creed. So I was moved by the discussion. I think, just to end, for my part, Sabina's, the bookend both of Sana's comments now Sabina's challenging us on the suppositions of the hierarchy, and to be very aware that in these partnerships, there is a deference. There's a deference to individual hierarchy and, resume and institutional and national or political, all of these things play into it. And so I think those are cautions and challenges for us to take forward in this effort. And I've already taken too much time. So, but thank you all for what was just brilliant participation. Over.
Any final remarks or closing remarks, comments, or questions from our moderators and panelists before we wrap up? I know you're not shy. You had a lot of opinions, but you can also go ahead. Go ahead.
I would
Rachel.
just say, just very quickly, and again, this is just in support of the way that you created the architecture for this whole satellite. I do feel like it's really critical to hear from these different perspectives, and so I really do appreciate sort of the richness of the offerings that from implementers and around academics, and sort of trying to think about what the different needs are and where the gaps are, and sort of crosswalking between these groups. So I just appreciate this, what I hope would be the beginning of a larger conversation. But I think there's a lot of learning that has happened and can be done. So thank you.
Thanks. Thank you. We also agree. We hope this is the beginning of a continued conversation. So thanks for that, Laura.
Emily, can I just quickly build on what Rachel said? I think one of the common themes that I've heard is this need for new language and need for, the key to good partnership, regardless of whether it's for IS or anything else, is communication. So I think a lot of what we're talking about is how to foster that, who to bring to the table, whose voice is heard and how. I think we ended with, what I think is a brilliant comment by Sabina, where she flipped the language of how we think and talk about capacity building in terms of thinking about capacity sharing. And I think that's a really lovely way to think about the importance of language and how we all engage with it. And we all need to engage together to make IS work. So thanks.
Thanks, Laura. Great points. Any other comments? No, I think we've been left with a lot to think about and many different directions to take the next set of conversations. So we thank you for your time. We know 3 hours is a lot of time to ask. We're really grateful to all the speakers, the moderators for their excellent work. And we'll be following up with a report. We will have all of the materials shared on our website. We'll also email them to you, and we look forward to the next conversation. Thank you so much.
Thank you.
Thank
Thank
you.
you, everyone.
Bye, everyone. Thank you.
Thank you.